We have another excellent issue this month, beginning with an article from Diabetes Care where we will be talking to one of the authors about the age of diabetes diagnosis and the lifetime risk of dementia. Some really incredible insights here. Then we're going to be talking about an article from JAMA Open Network on GLP-1s and 13 obesity-related cancers in patients with type 2 diabetes. What is the effect of GLP-1s on cancer outcomes? Then an article from Annals of Internal Medicine on the association of semaglutide with tobacco use disorder in patients with type 2 diabetes. Again, a real-world study looking at the effect of semaglutide on does it help people cut down tobacco use? Then an article from The Lancet, a really important article on blood pressure management. Target doses for blood pressure have been controversial over the years. This is an article on lowering systolic blood pressure to less than 120 millimeters of mercury versus less than 140 in patients with high cardiovascular risk, including those with diabetes. We'll see what this article says. And then finally, an article from Diabetes Care on long-term neurobehavioral and metabolic outcomes in offspring of mothers with diabetes during pregnancy. For our first article this month, we will be discussing an article from Diabetes Care titled Age of Diabetes Diagnosis and Lifetime Risk of Dementia, the Atherosclerosis Risk in Communities Study. This is a critically important topic because, as we know, people with diabetes are at significantly elevated risk of developing dementia. Joining us to discuss this article is one of the authors, Joseph Koresh. Dr. Koresh is the founding director of the Optimal Aging Institute and a professor of population health and medicine at the NYU Grossman School of Medicine. Welcome, Joe.
Thank you. Good morning.
Joe, can you discuss a bit of the background on diabetes and dementia and why you chose to look at this issue?
Sure. We've been interested in the vascular basis of dementia for a long time. And the rationale is that we know how to treat vascular disease and prevent vascular complications like heart attacks and strokes. Whereas for dementia, the neurodegenerative component is much harder to change. But for a while, we suspected that they're connected, and we and other groups have shown an intimate connection where diabetes and other midlife risk factors are associated with accumulation of amyloid in the brain. And that then suggests a strategy for prevention of both stroke, microvascular disease, and the amyloid deposition that's involved in Alzheimer's disease.
And that's pretty exciting in its potential. How did you look at this? What was the methodology for this study?
Yeah, so we think that in order to understand human disease like dementia, we need very long-standing cohorts, right? Because fortunately, the processes underlying dementia are slow, but they are progressive. So we see that heart disease often occurs earlier, but with reductions in risk and survival, people live past the age of 65, where dementia risk starts increasing, past the age of 75, where dementia risk becomes significant, and then past the age of 85, where dementia risk becomes huge. So we need to look at all of the above. And so we've taken a heart disease study that was started in the 80s and added a major brain component in 2009. And we've just renewed it to look at latest onset dementia until 2029. And it's called the ERIC Neurocognitive Study.
Very exciting. What were the results?
So for this paper, we focused on diabetes and pre-diabetes. So we were interested in whether the current definition of pre-diabetes, and it's another discussion as to whether there's a way to optimize that definition because so many people have it and it's variable. But the current definition, we were interested in, is it associated with long-term risk of dementia? And in fact, we found that there was a small but significant risk of dementia decades later. We were then interested in whether that risk mostly happens in people who develop diabetes or happens in people who just stay in the prediabetes state. And we found that the risk was largely explained by people who transition to diabetes. And then finally, we were interested in the age of onset of diabetes. And we found that really earlier age of onset was dramatically associated with increased risk of dementia. If you had your diabetes onset before the age of 60, you had 3 times the risk of dementia. If you had your diabetes onset by the age of 70, it was 2 times. By the age of 70 to 79, it was 1.26, only 30% higher. And after the age of 80, only 15% higher. So the implication is that delaying the onset of diabetes can really reduce the hazard of dementia.
This was an amazing study because 25 years of follow-up really gives us solid data. There are over 13,000 participants, and we know that there's ways to delay the onset of diabetes. The granddaddy of all these trials was the Diabetes Prevention Program in New England Journal 2002, where we saw that rigorous program of diet and exercise decreased progression from exactly the group you were talking about, pre-diabetes onto diabetes. What are your thoughts about how we might either communicate this information to our patients or use this information in our offices?
I think in terms of communication, people recognize that diabetes is a problem. People think of heart disease, but I think in the last 10 or so years, it's become clear, and now we need to make sure the public and physicians register that dementia risk is linked to vascular disease risk. And that means that a lot of dementia risk can be reduced with many of the same strategies for reducing heart disease risk. It's not going to solve everything, but it's going to be a big help for dementia risk, particularly before the age of 85.
Such important information that we can use tomorrow. Joe, thank you so much for joining us.
Thank you very much for the opportunity to talk about this.
For our next article, we have an article from JAMA Open Network titled GLP-1 receptor agonists and 13 obesity-related cancers in patients with type 2 diabetes. There are 13 human neoplasms that have been identified as obesity-related cancers. That means that the presence of excess body fat is associated with an increased risk of developing that cancer and a worse prognosis in patients when they get those cancers. The question was, the GLP-1s clearly are effective at decreasing obesity. They're also very effective in treating type 2 diabetes. What would they do to the incident risk of these cancers? And to look at this, the authors did something very interesting. They did a retrospective cohort study based on over 113 million United States patients from a large database of electronic health records. And the study population included over 1.6 million patients with type 2 diabetes who had no prior diagnosis of obesity-related cancers and who were prescribed GLP-1s, insulin, or metformin all the way from March 2005 to November 2018. And the data analysis was conducted in April 2024. So there's this large study population, 1.6 million patients with type 2 diabetes. Average age was almost 60. Half were male, half were female. When they looked at GLP-1s compared to insulin, GLP-1s compared to insulin were associated with a significant risk reduction in 10 of the 13 obesity-related cancers, including gallbladder cancer, meningioma, pancreatic cancer, where the hazard ratio is 0.4, hepatocellular cancer, a hazard ratio of 0.47, ovarian cancer, hazard ratio of 0.5. Remember, that hazard ratio, that 0.5 means about a 50% decrease in the risk in that case of ovarian cancer. Colorectal cancer has a ratio of 0.4, 1.54, multiple myeloma, kidney cancer. GLP-1s were not associated with the reduced risk of postmenopausal breast cancer or thyroid cancer. Of the cancers that showed a decreased risk among patients taking GLP-1s compared with those people who were taking insulin, hazard ratios for patients taking GLP-1s versus those taking metformin for colorectal and gallbladder cancer were less than 1, but the risk reduction was not statistically significant. Compared with metformin, GLP-1s were not associated with a decreased risk of any cancers and were associated with an increased risk of kidney cancer, a hazard ratio of 1.54. John, I'm so interested in your thoughts here.
A very powerful study. Usually, when we're thinking about medicines for diabetes, we're thinking about glycemic control. And in this particular study, one would think that insulin could just be just as effective, if not more effective, than the GLP-1s for glycemic control. So whatever that we were seeing here is not necessarily glycemic control. It's a weight loss related thing. If these are obesity related cancers, this is pretty powerful. When we think about the burden of malignancies, and actually when you look at a lot of the things on the list, we only screen for about 44% of the cancers that actually occur in the United States. So not only is this something that are really good medicines for decreasing MACE, for perhaps helping kidneys do a little bit better and losing weight. It's becoming harder and harder to not argue that these should be a first line agent when you think of things like esophageal cancer, that for the majority of people who have esophageal cancer, by the time it's going to present, it's going to be very late. Certainly, we want no one to really become obese. And if you could prevent obesity, could you prevent a large chunk of these obesity related cancers? So I think this is just one other log on the fire for the GLP-1s as an argument as we're thinking about it. And if you look at standards of care, it really says we should be thinking about something that can help a patient lose weight if they are obese, even before we would add metformin, which is different than we were doing 7 or 8 years ago. So our next article comes from The Lancet, and it looked at lowering systolic blood pressure to less than 120 millimeters of mercury versus 140 millimeters of mercury in patients with high cardiovascular risk with and without diabetes or previous stroke, an open label, blinded outcome randomized trial. So this particular study that was open label, blinded outcome randomized trial used minimized randomization to assign participants to either intensive treatment, standard official office systolic blood pressure of less than 120, or standard treatment, which would be less than 140. Primary outcome was a composite of myocardial infarction, revascularization for heart failure, stroke, or death from cardiovascular causes. The study went on from September of 2019 to July of 2020. They had over 11,000 participants who were randomized to getting the intensive treatment, which was about 5,600, or standard treatment, which was about 5,600. The median age of the participants was 64.6 years of age. The mean systolic blood pressure throughout the follow-up, except for the first 3 months of titration, was 119 millimeters of mercury of systolic blood pressure in the intensive treatment group, and 134.8 in the standard treatment group. During a median of 3.4 years of follow-up, the primary outcome occurred in 9.7% of participants in the intensive treatment group versus 11.1 in the standard treatment group, for a hazard ratio of 0.88, so a 12% decrease. There was no heterogeneity of the effects of diabetes status, duration of diabetes, or history of strokes. Serious adverse events of syncope occurred more frequently in the intensive group, 0.4%, versus the standard treatment group, 0.1%, of a hazard ratio of threefold. But overall, the raw numbers were relatively low, less than 10 in both groups. There was no significant between group difference in the serious adverse events of hypotension, electrolyte abnormality, injurious fall, or acute kidney injury. Neil?
John, this study is a big deal. We've had a lot of different studies over the years that say different things. We've known for a long time a systolic less than 140 is important. And that's what most of the guidelines out there still emphasize. Recently, the American Academy of Family Physicians said a systolic less than 140. The International Society of Hypertension has an interesting recommendation. They say less than 140 for most, but optimal blood pressure less than 130. And the American Heart Association, primarily based on the SPRINT trial, recommends a systolic blood pressure less than 130. Recently, a year and a half ago, the American Diabetes Association changed their recommendations from what had been a systolic less than 140 to what is now a systolic less than 130. Originally, they had the 140 number because the ACCORD study did not show an improvement on aiming for a lower blood pressure, but it did show a decrease in the risk of stroke. So to align better with that outcome, as well as the American Heart Association, the American Diabetes Association switched their recommendations to favor a systolic less than 130. So that's the big recommendations that are out there. But really, the trial that stood out, that supporting the lower blood pressure, was the SPRINT trial. And there had been questions raised about the way the blood pressure measurement was done in that trial. So there hasn't been incredible agreement. This trial just sends that question, I think answers that question. They did a well-conducted, controlled study. They achieved blood pressures less than 120, as you went over, compared to blood pressures less than 140 was, I think, 134. And they showed a significant decrease. Now, what was interesting, John, one might not be that impressed with the hazard ratio of 0.88, that 12% decrease, but that was because this was a 3.5-year trial. If they only looked at the comparison after a year, because during that first year, there's not a lot of difference in blood pressure. And where they started seeing those curves diverge was after a year. When they just looked at the time period after a year till the end of the trial, the hazard ratio was 0.78, so a 22% decrease in the MACE outcomes in the more aggressively treated group. The other point that was important, the component of the primary analysis that stood out, was death from cardiovascular causes, which, while it was not large absolute numbers, was a large decrease. So that was 1.1% in the intensive treated group and 1.7 in the standard treatment group, for a relative decrease of almost 40%. So I think at this point, and it's important to remember, this was in people who had an average age of about 60, and I think the average age was actually 64, and all of whom were at elevated cardiovascular risk, meaning they either had cardiovascular disease or they had 2 or more cardiovascular risk factors. One of the risk factors, of course, being, as we saw here, people with diabetes. And as you said, the results stood up to subgroup analysis in people with diabetes and people with stroke, etc. So I really think this creates a pretty strong argument for aiming for that lower blood pressure in people at high cardiovascular risk. Our next article is from Diabetes Care and is titled Long-Term Neurobehavioral and Metabolic Outcomes in Offspring of Mothers with Diabetes During Pregnancy, a large population-based cohort study in Ontario, Canada. This study looked at offspring of women with diabetes because we know that people with diabetes are at increased risk of developing both neurobehavioral and cardiometabolic disorders. This was a population-based cohort study of deliveries in Ontario between April 91 and March 2018. Women had pre-existing diabetes, gestational diabetes, or no diabetes, and the goal was to examine the risk of developing ADHD, autistic spectrum disorder, and cardiometabolic outcomes in offspring, and to look at the association between those things and between pregnancy A1C. A total of over 3.4 million mother-infant pairs were followed for up to 29 years. Offspring of women with type 1 diabetes had the highest risk of ADHD with a hazard ratio of 1.43, of autistic spectrum disorder, an almost doubling of risk, a hazard ratio of 1.94, diabetes, a hazard ratio of 4.73, hypertension, a hazard ratio of 2.5, and cardiovascular disease, a 70% increase, hazard ratio 1.7. Next up were women or offspring of women with type 2 diabetes and gestational diabetes compared to those unexposed. Among women with pre-existing diabetes, there was an association between the level of pregnancy A1C and offspring having diabetes, hazard ratio 1.22, hypertension, hazard ratio 1.4, and cardiovascular disease, a hazard ratio of 1.2, but no statistically significant association with any of the neurobehavioral outcomes. John?
So, Neil, an interesting study. I think when we think about gestational diabetes, we certainly do think of some inherent fetal risks. So, babies are more likely to have macrosomia, more likely to have birth trauma, more likely to lead to a C-section. They are more likely to have elevated bilirubins, or more likely to be stillborn. Certainly, there are some inherent risks that we know about, cardiovascular, congenital heart disease associated with it. There are things that have been around for years and years, and I just listed a whole bunch of things. Thinking about some of these neurologic things, I think, is a little bit newer. And I think when you look at some of the raw data, patients with type 1 diabetes do the worst. And the authors talk about modifiable risk factors. Our patients with type 1 diabetes can have some impact on their control of their diabetes. They can impact whether they've developed type 1 diabetes. Certainly, we have people can have some impact on whether they develop type 2 diabetes. And really, for every condition, type 2 diabetes does worse than gestational diabetes. So certainly, if we can keep people out of being in the type 2 diabetes bucket. And then if you look, for the most part, gestational diabetes does a bit worse than not having diabetes at all. So I think for all of these things, we really want to think about primary prevention. And for some of the things, some of the cardiovascular things, what the A1Cs are in these moms can have a huge impact, at least for some of the hypertension and some of the heart disease things. Some of the neurologic conditions, the statistical significance does not seem quite as strong for things like autism spectrum disorder and things like that. So I think if we need yet another reason to ask someone to get their blood sugars under control before they conceive, I think this paper throws a couple more logs on the fire, that when we're talking to our moms who are contemplating getting pregnant, who've had some impaired fasting glucose or have some poorly controlled type 2 diabetes, that if they can really work on getting a little bit of their metabolic house in order before they get pregnant, they could have some lasting impact in their child's health going forward.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.